Okay, great. Can you hear me now?
Yes, we can.
Perfect, perfect. So I think it's just fantastic to have so many people here for this. And what I really wanted to do, thinking what might be of practical importance, and since this week I've been spent on consults, I thought might be helpful to discuss the whole concept of preoperative evaluation, cardiac evaluation of our patients, and bring in a little bit about what role EKGs plays in that. But I thought it might be helpful to look at this in a much more holistic fashion. And I don't know if I'm sharing my slides, Deborah, am I?
Not yet. I just see your background.
Okay. Let's see. There we go. Options. Let's see if I can make this work. I'm sometimes technologically challenged here. That working?
Yes, we can see your screen and now we see objectives.
Okay, great, great.
Yep, there you go. Perfect.
Okay, so I want to talk a little bit about preoperative risk assessment. All very often, whether patients in office of a primary care provider or the office of a surgeon or in the hospital, often it's felt that for one or several reasons, sometimes because a patient has some preoperative cardiac condition, or sometimes just based on the patient's age and comorbidities, it's felt that the patient should be sent for cardiovascular evaluation. And often when we get those patients, it's sort of referred to us as, well, we want you to see this patient for cardiac clearance. And the first thing I want to say is that we really don't clear patients for surgery. The role of the cardiologist for cardiovascular preoperative evaluation is to assess what's the cardiovascular risk for the patient, make recommendations for how we might optimize the patient for their upcoming procedure. And most importantly, I feel like we should never, ever lose out on a teaching moment. So most importantly, weigh in on the postoperative care. And if the patient has cardiovascular risks, see if we can't take advantage of that moment to help the patient live a healthier life even after their procedure. So my objectives today are just want to review a little bit about the essentials of patient evaluation, history, physical, and most importantly, medical reconciliation. Talk a little bit about the risk stratification tools that we use. Talk even more about some of the preoperative diagnostic tests that we often get. For example, most patients before surgery will have an EKG done. But often there's questions as to whether other tests should be done. Should a patient have a stress test, labs? And then spend a little bit of time discussing just how we optimize the patients for surgery, optimize management, and then what are some of the things we can do to take advantage of that moment to improve the patient's overall health? Because at the end of the day, this is in fact a team concept, and the patient is really the most important member of that team. So one of the things we definitely want to do when we see patients is first identify patients who are at highest risk for going through their procedure. And that doesn't mean that we will say the patient shouldn't have the procedure, but we want to make sure that the benefit of that upcoming procedure is such that that it outweighs the risk. So identifying the patients who are at high risk, making recommendations for perioperative management of patients, and always including the patient in the decision-making process, especially if we know the patient is at intermediate to high risk for the procedure. Sorry. Let's turn off all these devices. So from a cardiologist standpoint, one of the things that's most important to me when I see a patient is, what's the patient's risk of having a heart attack at surgery? What's the patient's risk of developing heart failure or developing decompensated heart failure? And what's the arrhythmia risk, or how do we manage arrhythmias if it occurs in the perioperative period? So I want to start off with a case that, interestingly enough, is one of the consults from today. So this was a 78-year-old female, very active 78-year-old female, who had what we call a ground level fall, but actually she fell down several stairs, 10 stairs in her home. Ended up with multiple rib fractures and fractures in both of her arms, and a humeral fracture. From the rib fracture, she developed bilateral pneumothoraces. From a past medical history standpoint, she didn't have much going on. She had type 2 diabetes, which was well controlled. She's really on top of that. The only medicine was metformin, and extremely active. So she was a pleasant, well-developed, well-nourished female who was in no acute distress at the time that I saw her today. And heart rate at the time was 70, blood pressure 135/71, respiratory rate 15. Really looked great sitting in the chair, although she had bruises on her face, as you would expect, and head. She had splints on both arms. One arm was in a sling. And in spite of her bilateral pneumothoraces, which now had been resolved, her lungs were now clear. Cardiovascular exam was not that remarkable, other than a grade 2/6 murmur, and she didn't have any jugular venous distension. So amongst the things that we discuss when we see our patients is using our risk calculators to calculate a risk score. So based on the data that I've given you, her RCRI risk score, which is one that we use often for our patients, probably the most common risk score that we use in academic medicine, was 0, which is a good score. Low score, the better. From an RCRI standpoint, her medical or risk or cardiovascular risk was low. Just as important, if not maybe more important, is something called a DAISY score. And this is the Duke Activity Score Index. And it was a little low. So the higher, the better. And below 34 is considered higher perioperative risk for any patient. It means they're not as active. They may be a little frail. Now, as I said, she was in her 70s. I have to admit there were a couple questions on the score that I didn't ask her about. Although her husband was in the room, one of the parts of the score is asking about sexual activity, and I didn't ask that question. So that's how she could have gotten up to 28.7, but I didn't ask that. Just last year, ACC actually gave us a new set of guidelines for perioperative cardiovascular management. And I would encourage everybody to take a look at these. You don't have to read the entire 100-page document, but breezing through the highlights or even creating a highlight view, I think, is tremendously helpful. But I think it's also important for us to look at the levels of evidence for each of the recommendations and remember to put that in perspective for the patients. and recognize that when a patient is sent to us as cardiologists, that's what we're doing. I gave you the history. I didn't give you a complete history because there's a bit of a spoiler alert for the end of the talk. So a patient evaluation and history are still extremely important, especially in these days and times. I know we rely a lot on the labs that we can find or we can find in the medical records. Whether the patient had studies, x-rays, labs, etc. But actually sitting down, talking with the patient, we find is exceedingly important because it helps us to put things in much, much better perspective. And in reality, although the guidelines might suggest that we should do a comprehensive history and physical, really it's probably more important to do a focused history and physical. So one, focusing on issues like cardiovascular risk factors. Are they diabetic? Are they dyslipidemic? Are they hypertensive? Do they have obstructive sleep apnea? Is the patient obese? Those things are exceedingly important when we think about what the patient's ultimate outcome is going to be from their procedure. Have they had any other cardiac events? Have they had stents? You know, for us, one of the things that's important if someone is anticipating a procedure that may be necessary, not emergent, but maybe necessary or even urgent, if they've recently had stents placed, coronary stents placed, what are we going to do with their dual antiplatelet therapy, for example? Do they need a bridge? Is it something where the procedure can be put off for 3 to 6 months till they're at least 6 to 9 months out from their stent placement, although we'd like that to be a year? Do they have any family history that might suggest that they're prone to complications of the surgery? Getting a focused history based on the things that are important to us is extremely important. Physical exam, again, full disclosure, being honest, I think in these days and times, it's very rare that any provider does a truly comprehensive physical exam. There's not time for it. So that means our physical exam has to be focused. And, what I share with the residents and the fellows is that, try and at least be methodical. Start at the patient's head. And remember, the first part of the physical exam is observation. So, for example, if a patient has that dry stuff at the corners of their mouth and they've got multiple liquids on the table next to them, they may be dehydrated, and that might be why the blood pressure is lagging. But then for us, jugular venous evaluation is exceedingly important because one of the conditions that are most likely to lead to a poor cardiovascular outcome in patients who undergo surgery is decompensated heart failure. So exceedingly important that we start there. I say start at the head, go to the lungs, then go to the heart. It's important, even though it's the age of echoes, that we actually do a cardiac exam, listen to the heart sounds, make sure the patient doesn't have aortic stenosis, for example, which could be an issue if it had not been diagnosed prior to this, especially where the patient had a cardiac arrest in the procedure. Does the patient have a significant mitral regurgitation murmur? Does the patient have an S3, which may suggest or would suggest the patient has decompensated heart failure? That's a sign that's not very sensitive, but extremely specific. So actually doing a cardiac exam, at least listening in your major 4 areas, for us it's important, but that can be picked up even before the patient is sent to us, so we know how to focus the remainder of our evaluation. one of the things that is extremely useful to us is a thorough and accurate medication reconciliation. It's of utmost importance. The patient today, for example, although when I saw the patient, heart rate was 70 and fine, looking through the records, the patient had heart rates in the 40s and 50s during the hospitalization. One of the reasons that they called us was because the patient had another arrhythmia prior to us seeing her. So doing a thorough medicine reconciliation is extremely important. And we actually got the history of beta blockade use from the patient. It wasn't as well documented as I would like, although it was in the record. Sometimes the medication can give us a clue to what the patient's diagnosis is. For example, anytime I see a patient who's on an SGLT2 inhibitor, I always ask them, okay, are you on this for diabetes, or did someone tell you they have heart failure? It's amazing to me how often we run across patients who have never actually been told they have heart failure. They've been told that they have a heart that's a little weak. They've been told that they have, the pump's not so strong, or the pump doesn't relax, but no one has told them they have heart failure, and that's extremely important. But sometimes from the medications, they will give us context clues that help us better assess what this patient's cardiovascular risk is, or risk of having an adverse event during the procedure, or need for doing things to prevent those events prior to the procedure. And certain medications we know need to be adjusted prior to their procedure. So patients can have surgery, and we know we have to stop their SGLT2 inhibitor to prevent DKA, euglycemic DKA episodes during the surgery. So knowing and having a very good and detailed and thorough medication reconciliation is tantamount to getting a good result with our surgery. Now the good part, and this is rather interesting. We have a lot of cardiovascular risk tools, and the guidelines actually recommend, and actually it's the first recommendation in the guideline, is that we use these risk tools to assess our patients. When we look at the level of evidence, it's a level of evidence that's not based on randomized studies, and it's a 2A recommendation. So it's felt to be a useful recommendation. I think it is, but we always have to put this in the context of our patient. So as I said, with our patient, looking at her RCRI risk calculation, she was a 0, considered low risk. There are a number of other indices that you can use. You can choose whichever one you want. If you actually, and I know this is a busy slide, but it's just to give you an idea of how many risk calculators we have, but also looking at when we actually develop these risk calculators. So for example, RCRI, I don't know if you can see it that well on the slide, but that was from 1989. The Goldman Index of cardiac risk, which is one that some people still use, is 1977. A lot's happened since then. And I encourage folks, just when you have a little time, just to sort of peruse through these, because they're very, very different. I think one of the better risk calculators is actually the American College of Surgery NQSIP score. That takes into consideration 21 different elements, and it actually, I think, helps us get a better idea of what are the chances that our patients will make it through surgery. and whether we should do surgery now or wait to optimize. This is another busy slide that goes through just the steps or the algorithm that has been set out for us for doing our evaluation. And I'm not going to go through it in detail because we're going to touch on several of the elements of this, but I think it's exceedingly beneficial for everyone to look at the algorithm. Now for the good stuff, because as a cardiologist, one of the things that happens so often is patients are sent to us for, to do quote unquote cardiovascular clearance. And sometimes people want certain tests done or have done certain tests, and now they have a result. And that's why we're seeing the patient. So one of my favorites is does this patient need a stress test prior to their surgery? So let's talk about some of the non-invasive tests. There's a role for echo in given patients. There's a role for stress testing in given patients. There's a role for other forms of non-invasive testing or minimally invasive testing. But all of this should be based on the patient's risk and need. Otherwise, we have the possibility of unintended consequences occurring from our testing procedures. One of the most common ones is EKGs. When should we get EKGs, and when are they beneficial? So if a patient has known coronary artery disease, known arrhythmias, peripheral artery disease, things that we know that put them at risk, we know those patients should have an EKG prior to surgery. In a patient that has some new abnormality that makes us think that it's reasonable, they've got chest pain, they've got something going on that makes us think it would be reasonable for us to get an EKG, absolutely we should get an EKG for that patient. The evidence isn't quite as strong for patients who are asymptomatic and going through surgery, but still recommended because I do think that getting an EKG in somebody who is 50 years old, asymptomatic, but has several risk factors that puts them in intermediate risk. I think it's good to get that baseline because all too often something happens and then everyone is looking for, what did the EKG show? So I think getting an EKG on those patients, I think is beneficial. Getting EKGs for an asymptomatic patient who otherwise has low risk is not recommended. It has no benefit and actually can cause harm in that there are times that things are seen, in routine EKG that may hold up a surgery that's necessary, so it's delayed. It may lead to other testing that could ultimately be found to be harmful for the patient. And sometimes it just creates an issue where it's just costly to go through additional unnecessary testing because we got an EKG on a patient who was low risk, 40-year-old, subcutaneous surgery, removing, let's say, a lipoma, and routine EKG now shows first-degree heart block. And so the patient is referred to a cardiologist because the computer read an abnormality, and it sort of delays the procedure, although it wasn't urgent, and increases cost to the patient and our health system that really wasn't necessary. So the judicious use of all of our diagnostic modalities is just exceedingly important. Biomarkers can be particularly helpful, especially in patients who are either over the age of 65 or patients who have other significant risk. The two most beneficial biomarkers are troponins and BNPs, because we know that patients may not have had a heart attack, because troponin should be read in the setting of what are the symptoms that are going along with it. But we know that someone that has chronically elevated troponins has increased perioperative cardiovascular risk. They're almost 67% more likely to have an adverse event. So pre-op troponin in a patient with known cardiovascular disease, or who's over the age of 65, or patient over the age of 45 who has multiple comorbidities that increase their risk of having cardiovascular disease, is very, very helpful. So is the use of pre-op BNP or NT-proBNP. BNP is a great test because BNP doesn't actually tell us the patient's in heart failure or not, but it does give us a window into whether this patient has increased what we call left ventricular wall tension. So are the pressures inside the heart higher, which would suggest that it may be hypertensive cardiovascular disease, but it may cause us to have issues with things like fluid management of the patient perioperatively. So biomarkers can be helpful, but again, it has to be focused on the particular specific patients for whom it will be beneficial. Stress testing. Now, I have to admit, this is one of my pet peeves, because we often look at stress testing as a panacea, and it is, throughout medicine all over our country, is overutilized. And I'm always concerned for two things with stress testing. One is that we identify patients falsely as being at low risk because of a stress test or stress test result, or we identify an abnormality in our stress testing, which leads to other things being done that would otherwise not have needed to be done. So per the guidelines, stress testing should be used if, outside of having this surgery, the patient would benefit from a stress test. So is this someone that you need to do a stress test that has indication of a stress test? Quick story, because I think we have a little time. And this has happened more than once in the course of my practice, but people who've had stress tests for dubious reasons, who ultimately went on, because of an abnormal stress test, to have, cardiac catheterization. And then as a result of cardiac catheterization, an obstruction was found and they were stented. And on more than one occasion during my years of practice, I've dealt with patients who were asymptomatic, who were stented, and the result was, because they may not have been as adherent to the dual antiplatelet therapy as they should have been, it resulted in them suffering from an acute MI, from acute instant thrombosis. And one of the patients I remember very vividly, actually massive anterior MI for an 8, because he had a stented early mid-LAD stenosis, occluded, infarcted, developed heart failure. So stress testing should be reserved for patients who would otherwise need stress testing. Otherwise, it shouldn't be ordered as part of your perioperative or preoperative evaluation. The other concern that I have with stress testing is when stress testing is ordered without considering what is the patient's pre-test risk of disease, then often it can give us a false sense of security. Again, and I can pull from very recent experience from this week on consults, a young lady that we saw who had a troubling history, but had had a stress test done with nuclear imaging, and there was a small defect, folks said, well, your pain doesn't sound really typical. She arrived back in the hospital today. When we did I think a bit more thorough history, found out that she had significant decreased exercise tolerance, given the things that she did, because she had been very active and now was not as active anymore. She, in fact, had a stress test, and because some people can have what we call balanced ischemia, stress test didn't look that terrible, but she had 3 vessel disease, and she'll probably undergo surgery before the end of the week. So stress testing should be used in the appropriate patients at the appropriate time, and is rarely ever part of an evaluation for surgery, except in very rare instances. For example, I know it's in the current recommendations to have dobutamine stress testing for patients who are going to undergo liver transplant. So the takeaway from this is, don't order a stress test to risk stratify a patient for any type of surgery. Echoes can be exceedingly important. And if a patient is symptomatic, we have excellent evidence, and it's a strong recommendation that patient should undergo echocardiography prior to cardiac cath to evaluate left ventricular function, and not just systolic function, but also diastolic function, because we do know that one of the major reasons for patients to have adverse outcomes from any type of non-cardiac surgery is decompensated heart failure. So that's level one. That's a level 1 recommendation. Still no randomized study, because it wouldn't be ethical to do a randomized study for patients who need echo, but very strong evidence that getting an echo can be beneficial for the patient prior to their procedure if they have symptoms that might suggest heart failure. In patients with known heart failure and have some change in their symptoms, so you know that the ejection fraction is, let's say, 40–45%, but on that focused history and focused physical exam, you find evidence that the patient may now have some change in their symptoms. It's strongly recommended, and again, that's a 2A recommendation, that patient should undergo echocardiography. In asymptomatic, clinically stable patients, routine evaluation of left ventricular function is not recommended. And again, sometimes it can lead us down the wrong path. So that's really something that should not be done. So just getting an echo routinely just because, not a recommendation. It's of no benefit. And in some cases, I really believe the way we think about those results can result in harm to our patients. A wonderful and useful test, I think, for us nowadays, where it can be utilized is coronary computed tomography, CCTA, or coronary angiography. It's a wonderful test, especially for patients who are known to be at elevated risk with their surgery, maybe a higher risk surgery, and have decreased functional capacity. So they can't do a stress test. Now, the caveat to that is sometimes, especially if it's an older patient, or it's a patient who's diabetic, or a patient who has significant renal disease or is on dialysis, they'll have significant calcium. So we can't truly assess the level of stenoses in those patients who have a lot of calcium. One of the things that I think is helpful is if a patient's had a chest CT for any other reason, take a look at the report. The radiologist almost always report on whether they happen to see any coronary calcium, and that helps us know whether that might be a useful test for that patient, but can be extremely helpful and help us avoid, if necessary, going on to a cardiac cath if that wouldn't be beneficial. For patients who are at low perioperative risk, CCTA should not be done. It's a waste of resources. It's not helpful. And again, it can lead us down a wrong path if we happen to see a stenosis in an asymptomatic individual who is otherwise at low risk. And now we decide to go on a more invasive pathway on that patient. So would avoid CCTA in patients who are at low risk, and in fact, it's no benefit, and in rare occasions can be harmful. Last is cardiac catheterization. And per our guidelines, there is no benefit to perioperative cardiac cath. It's not recommended for non-cardiac surgery. And if the cardiac cath should be done, it should be done because there's an indication for the cath separate from the surgery, but not as a risk assessment tool. So if there's a patient who, we feel should be operated on is considered a procedure, but they have symptoms consistent with accelerating angina, maybe new EKG changes, then definitely they should be capped. But for our patients who are being evaluated preoperatively with no other indication for cardiac cath other than preoperative evaluation, that should not be done. Sometimes it will lead to, again, procedures unnecessarily. And it shows no benefit to, for example, revascularizing an asymptomatic patient prior to surgery, as well as if you put a stent in a patient like that, the surgery may be postponed because the patient will need to be on DAP for a period of time. So the next is our patient optimized for non-cardiac surgery? And this is of utmost importance. And as a cardiologist, one of the things that we do is not just give an assessment of risk that is in part based on our risk stratifying tools, but also taking in all the information, but also is optimized for surgery. So is the patient, for example, tachycardic? Are they having spells of atrial fibrillation with rapid ventricular rate prior to going through their procedure? Are they a chronic heart failure patient that may still be volume overloaded? Are they a bit over-diuresed, for example? And so between our exam or looking at lab studies and maybe doing POCUS, do they need to be, do they need to be liberalized on fluids prior to going through surgery? So preoperative optimization and management is exceedingly important. Are they on the proper medicines prior to surgery? Back to that medicine reconciliation, which should include a look at medicine compliance. Have they been taking their meds prior to surgery? All those things are exceedingly important. And when we look at our patients preoperatively, common issues, blood pressure control, diabetes, management, do we have their blood sugars in a reasonable range to improve their healing? That those things end up being exceedingly important to the ultimate outcomes for our patients when they're undergoing surgery. So last, and I think I can wrap up and leave a little time for questions, is what is our post-operative care supposed to be? Because at the end of the day, we have to remember it's not just about having a successful surgery. It's really about having our patients thrive. It turns out when a patient comes into the hospital for any procedure, but especially a surgical procedure, that ends up being a wonderful teachable moment. First, we obviously want to do our normal prevention, reduce thromboembolic risk for a patient. Do they need to be on anticoagulant after surgery? Depending on the surgery that's done, do they have adequate pain management so that they can move and decrease their DVT and thrombosis risk? But just as importantly as that is opportunity to look at the patient's overall health habits and make suggestions for ways that they can improve their lifestyle and make them thrive. This is a time when patients tend to be more receptive to things that we might say or recommend. Smoking cessation, weight management, dietary changes, physical activity, all of those things are exceedingly important. And I would say the most important thing for our patients when we think about a healthy life, healthy lifestyle. So I would strongly recommend that we look at this and say, this is an opportunity for us to talk to patients. As cardiologists, we're going to get history, we're going to ask about risk factors, and just mentioning, wow, your blood pressure really hasn't been under control, or, we noticed when we did your med reconciliation that you haven't really been compliant with taking all your blood pressure medicines. Wonderful time for us to make recommendations for lifestyle modifications. Remember that patients are part of a village. And so that information that we share with the patient, we're also sharing it with the family, both to help with the recovery of the patient, but also that information helps to foster better health for the family as well. Making sure we have a long-term follow-up. If the patient has a arrhythmia issue that we identified during the perioperative period, making sure that they're going to come back in. They may need event monitors or Holters. They may need follow-up echoes at some point in time, just making sure that those things are done. And again, remembering this is all a part of overall health for these patients. So don't let a moment or any patient encounter, don't let any of those minutes be wasted. In conclusion, so really it's important that we understand that we need a thorough but focused and pointed cardiovascular risk assessment when we see our patients, a good understanding of the patient's history. We need to employ the appropriate use of our risk stratification tools, and we need to optimize both the preoperative and postoperative care. Now, for that spoiler alert, for that patient, the things that I did leave out, even though we were called because the patient had an episode of atrial fibrillation with RVR, also some atrial flutter, which was wide complex, but she'd also had a liver laceration. She had dropped her blood pressure during the hospital, had spent times on pressors, and the last lactate they had was 3.2. So obviously, when we did our risk assessment, even though our RCRI was 0, and she was at some increased risk that probably came along with her advanced age, this was still someone that, when we made our recommendation, we did recommend to the team that it might be beneficial to delay by a few days her, repair of her humeral fracture, which is what they were going to do, give her a little bit more time to recover, and we would continue to see her and manage her and help manage her rhythm going forward. I thank everybody for being so patient on this cold winter evening, and I'd like to open this up for questions.
Thank you, Dr. Duncan. I don't see any questions in the chat as of now, but I have a question myself, if you don't mind me asking. So I know with these new guidelines, it was interesting that they discussed myocardial injury after a non-cardiac surgery, and they recognized that MINS was a predictor of increased 30-day postoperative mortality. And they advised outpatient cardiovascular follow-up for these affected patients. Do you have any thoughts on that? And any thoughts also on the antithrombotic therapy, to mitigate risk of events from occurring in the future?
So, yeah, I mean, and that's fascinating. That sort of goes to what I was saying at the end of the talk, of why it's important for us to look at this holistically. Absolutely. And sadly, I don't think we have a good way of predicting that, nor should we. And that goes back to the overuse of tests. So if we were to say we wanted to catch everybody that, or a much larger number of patients who might be at increased risk of post-procedure myocardial injury, then it probably would result in doing a lot of testing that would bring other people into that basket of leading to further testing. So I don't think we really have a good strategy for how to deal with that, other than dealing with it after the fact. Managing, again, like I say, those risk factors. And I really, my feeling is that that's one of those issues, and based on the case we just took care of, where I think there probably should be wider use of high sensitivity troponins. I'm not always a fan of those, but I think that's one of the areas where they can actually be.
Except when I send you a patient this weekend with 1 to 50, right?
That was perfect.
Any other questions? I'm gonna read one from one of our colleagues in Preoperative. Carol writes, do you think that CardioMEMS is a beneficial tool in heart failure patients preoperatively if they have this device?
Great question. So again, and this is personal preference, I have a love-hate relationship with CardioMEMS. They are wonderful when they work right, and the system also works well. Because, one of the things about CardioMEMS is, you put it in, one, they have to be calibrated well, and you have to feel comfortable with the calibration. Two, you have to have a system that supports getting the data and doing something about it in a proactive fashion. I think more often than not that doesn't happen. I don't think that CardioMEMS have a particularly robust role in preoperative evaluation, other than if the patient has signs of hypervolemia based on their CardioMEMS data pre-op, that you need to decongest them prior to surgery so they'll have a better outcome. In reality, the worst outcomes for patients are patients who have decompensated heart failure. Did that answer your question, at least give you my opinion?
Yes, thank you.
Okay.
There's another question. Maybe they want to know where they could find the guidelines that were referenced in the presentation.
Oh, so I know you can find it at the ACC website. It's multiple. Actually, if you can pull back that third slide, I can maybe pull that up. It may be in circulation as well, HA circulation.
Strom Carter, if you want to put your email in the chat, I'm happy to forward you an email that kind of went around with our VCU cardiology colleagues here, and I can forward that to you. Thanks. I'll send that to you.
Great, great.
Any other questions?
I actually have a quick question. So I know this is for in the outpatient setting. I actually work in the inpatient setting over at CJW. I've never thought to order a BNP or a trope for a patient, but also when they're coming in for surgeries, we usually see them more emergently. Someone fell, broke their hip, emergent gallbladder, et cetera, et cetera. Would you still recommend getting a trope level in those patients? Because I feel like in the acute setting, their tropes are more likely to be elevated regardless.
So as long as you recognize that the troponin you get is in the setting of an asymptomatic patient. So if there's nothing to suggest that this patient has a non-ST elevation MI for some reason, they haven't had symptoms, no hemodynamic changes, no dynamic EKG changes, it can be beneficial in a patient who has high cardiovascular risk because you have it as a baseline. So if you get the data, so good example is patient comes in, trauma, nothing, nothing's done. Then they have an episode where maybe their heart rate drops a little bit, or their heart rate goes up, or their blood pressure drops. And then you get a trope, and that trope is elevated. They just had fresh surgery and still never had symptoms. Now what do you do with it? Because this is a patient who has prior history of maybe stents, maybe diabetic. And so in that case, that trope can be really, really helpful in helping us know what our next step should be. If we knew it was elevated on admission and there's no significant change, then we know we don't need to look at it seriously. If it was very normal and now it's up to, you have a high sensitivity trope that was normal, now it's up to 150, or you have a trope that was less than 0.03 or 0.05, and now it's up to 0.9, that might be something real.
Perfect. Thank you so much.
Well, it's 6:30. Wow, that went by quickly. Thank you, Dr. Duncan, for your excellent presentation. Before we wrap up, just a quick reminder to please text the code on the screen within the next 48 hours. The code again is 36729. I'll put that in the chat. And do your evaluation within 30 days on the VCU Continue Education website. And I also put that in the chat. That is vcu.cloud-cme.com. As Dr. Hunley and Dr. Duncan mentioned, we're excited to see you at this educational series, and we hope that it grows across Virginia. And we encourage you to share it with your colleagues. Your feedback is invaluable, so please let us know your thoughts on tonight's talk and any additional topics that you would recommend that we cover in the future CME sessions for 2025 and hopefully for 2026. A special thank you to Dr. Hunley and Dr. Phillip Duncan, VCU Pauley Heart Center, and our committee members. And then also thank you all for attending. I know it was a cold, wintry night tonight. These sessions are going to be recorded and they'll be available on our YouTube channel for future reference. And again, if you would like any additional information or that email sent to you, my email is deborah.pora@vcuhealth.org. As we preview on what's ahead, next month's sessions will focus on valvular disease and current therapies, and that's March. And in April, we'll cover hypertension and resistant hypertension. So we appreciate your participation and look forward to seeing you at our next sessions. Thank you, everyone. Thanks, Dr. Duncan.